We wait for a couple of minutes more. It's 2 minutes past 8, so we'll wait for 2 minutes. Then start. કેમ છો શૈલેષભાઈ?
બસ fine, I'm fine. Sujay, morning session.
શૈલેષભાઈ was very regular in physical meet also.
Yes.
Right. Bhavin knows.
Yes, sir.
Yesterday only,
That's
Urjita came. Right.
Yes.
શૈલેષભાઈ still practicing full time or you reduce your hours?
No, reduce 12 to 3 only.
12 to 3 only.
Morning session only.
Right. Somebody else is handling your OPD or?
ના, પછી તો બંધ. એટલે હવે
Good. Semi-retirement.
almost.
So we start the meeting. Good morning, friends. Welcome back to Saturday Club of Vadodara meeting. And today we have very well-known ENT surgeon, Dr. Bhavin Parikh with us. He has been our guest speaker several times in the past also. He did his MS ENT from Baroda Medical College, MS University. Then he did his fellowship in otology at Rajiv Gandhi University of Health Sciences, Bangalore. He did his fellowship lateral skull base at Hospital Nord, France. And he's co-author of 2 books, Surgical Techniques in Chronic Otitis Media and Autosclerosis. Another book is Functional Surgery of CP Angle. And he has several publications, in fact, more than 20 papers in various journals to his credit. So he's going to talk about functional surgery of cerebellopontine angle, a new topic for all of us. So Bhavin bhai, thank you very much for agreeing to share your thoughts and work on this in this field to Saturday Club of Baroda. You have about 40-45 minutes to talk, and then we'll keep 10-15 minutes for interaction. So over to you, Bhavin bhai. Thank you.
Thank you, sir. And it is always my pleasure to talk in Saturday Club in front of all my teachers, whom we have looked forward as UGs and residents. And it is my pleasure to share my experience on this topic. Shall we start, sir? Or
Yes, we can start now. You can start the screen sharing.
So, this is as such a very small area of our body known as cerebellopontine angle. It's a space in posterior cranial fossa, which lies just behind the temporal bone. And that is how we ENT surgeon came in contact with this space, because the anterior part of this space is formed by temporal bone and the ear, and the posterior part is by cerebellum. And this narrow space has very important structures passing through it. Almost all the cranial nerves, from 3rd cranial nerve to 12th cranial nerve, all the cranial nerves that arises from brainstem passes through this space to enter into various foraminas of skull base and then exit into neck spaces or head and neck spaces. So this space, apart from important cranial nerves, has important arteries which supply the posterior cranial fossa. All the cerebellar arteries like superior cerebellar artery, anteroinferior and posterior inferior cerebellar artery, and the vertebral artery and the basilar artery. And the third important structure is the brainstem, as we can see here. After we remove the cerebellum, we are seeing the brainstem, which is divided into 3 parts: midbrain, pons, and medulla. And all the 3 has all the important cardiorespiratory centers and major cranial nerve nuclei into it. So this area has always been very critical, and there have been various approaches to access these areas, but with developing confidence and technology, the narrower and narrower approaches are being planned, so that the main purpose is not to make it cosmetically good, but it is to make it safe for patients. You do very minimal what is required and not do anything other than what the indication is. So that is not possible in all the pathologies, but there are some pathologies which we can assess through this approach. And so my topic today is to discuss this pathology, where we can go into cerebellopontine angle, deal with the pathology with minimum required action, and then come out. So this reduces the complications. This makes the surgery safer. And this is how this picture shows that with a endoscope, it is not completely endoscope surgery. It is endoscope assisted microscopic surgery. And it's the surgeries of this approach is known as minimally invasive retrosigmoid approach, or as I fondly say, MIRA. So this approach was it is one of the workhorse of neurosurgeons, the standard suboccipital or retrosigmoid approach. And my teacher in France, Professor Jacques Magnan, invented this minimally invasive retrosigmoid approach, especially for dealing with Meniere's disease patient. And how in 70s they had devised this approach, and at that time it was considered very dangerous that you cannot go into cerebellopontine angle with so narrow approach, and it can cause complications. But nowadays, more and more, almost most of the neurosurgeons have shifted to this minimally invasive retrosigmoid approach. So these are some of the views of CP angle by endoscope. We can see when we make a small narrow hole, craniotomy 2 to 2.5 centimeter just behind the sigmoid sinus, and when we enter inside, we can see all these cranial nerves, cerebellum, and the temporal bone. If I can show the marker, means just because these are the different cranial nerves, I will see my marker is not working when I am sharing the screen. But you can see there are lower cranial nerves entering into jugular foramen. The 8th cranial nerve, it will be better if I can label. Just a minute, sir. I can.
Yeah. The mouse cursor is not moving.
Yeah, it's not moving. It was moving. How it is moving, but when I do sharing, once we do sharing, it goes away.
It's okay.
But I can show here. So
Yes.
If you see this is the center of the CP angle, is marked by cochleovestibular nerve, or the nerve for hearing and balance. Just behind the nerve is facial nerve. The superiorly, this is trigeminal nerve. And these are the bunch of lower cranial nerves entering into jugular foramen. So all these nerves enter into different foramen of temporal bone. And why they are important, we will see. These are the views we get. And these views are not good just for looking, but this is the facial nerve. So root exit zone of facial nerve, you cannot see very well with microscope. But here you can see very clear. And there are special diseases which affect this area. So this is the foramen rotundum, through which the CSF comes out. So these are again different views with 30-degree endoscope seeing up. So we can see the facial nerve behind the cochlear and vestibular nerve, and these are the trigeminal nerve and lower cranial nerves. And so when do we see these patients as a patient? This was an anatomy, but where do we require actual implementation of this anatomy is there are certain diseases, mainly these are all functional diseases of cranial nerves. So cranial nerve, seventh, there are functional disease. Fifth, there is functional disease. Eighth, there are different functional disease of eighth nerve, which is cochlear nerve. There are different disease. Vestibular nerve, there are different disease. Ninth, glossopharyngeal nerve. So there are different pathologies which affect these cranial nerves in this CP angle. So I am sharing my experience. The most common indication is for vascular compression syndromes like trigeminal neuralgia, hemifacial spasm, and glossopharyngeal neuralgia. The second most common indication is Meniere's disease. This is one of the most difficult vertigo patients are Meniere's disease because they keep on having recurrent severe episodes of peripheral vertigo, and they are incapacitating. They reduce the quality of life of patients significantly. So these are the patients who will require this type of surgeries. And there are some small CP angle tumors like small acoustic neuroma or epidermoids where we can do this surgery. And in future, there are certain surgeries like auditory brainstem implant where this surgery can be done. So just going through, this is the general operation theater setup that is required. Now coming to the first indication, that is Meniere's disease. We know that vertigo is caused due to inadequate balance between two vestibular systems. So if the input from both vestibular system is equal, then patient will be balanced and stable. But if any of the vestibular system becomes dysfunctional, then patient experience vertigo. And most of the vertigo episodes will happen when the system will dysfunction only once. But Meniere's disease is one of the major disease where it keeps on becoming recurrently dysfunctional due to increase in pressure of endolymphatic fluid. So it is called endolymphatic hydrops. So this patient will have paroxysmal vertigo episodes. Initially, it starts once in a year or once in 2 years. Then it starts happening every month, and then every week almost they have severe vertigo, and they cannot work alone, they cannot drive vehicle. So it is this time that we have to, initially all the patients of Meniere's disease will be doing good with some lifestyle modification and medical treatment like Vertin and diuretics. But some of the patient, at least 30 to 40% of patients, will progress further and further with more episodes coming up around. And those patients will require some additional treatment apart from medical treatment. And there are different treatments like different surgeries. There is intratympanic injections of gentamicin. And so out of all these non-medical procedures, this vestibular nerve section is the most effective procedure to treat vertigo. So if we see the pathophysiology, it was because one side of vestibular system was becoming abnormal again and again. Our brain and cerebellum and brainstem has a very good tendency for compensation. So if it is a single episode, the cerebellum and the brainstem and the vestibular nucleus will compensate for it very well. Within 7 to 10 days, the acute part of vertigo will go, and within 6 to 8 months, the residual vertigo will reduce significantly. But what happens in Meniere's disease, by the time patient is getting okay with the acute vertigo, he gets another episode of severe vertigo. So these vertigo episodes keeps coming initially once in a year or twice a year, then it starts coming once or twice in a month, and there comes a time when the patient starts developing vertigo every alternate day. So then it starts affecting the patient's quality of life. He stops working or reduce the working hours, they stop driving, they don't remain alone at home. And that is the time when medical treatment, full maximum medical treatment is going on. And even after that, they are having vertigo. Then we have to consider for this surgery. And vestibular nerve section surgery has a success rate of almost 98%. and this is a safe surgery. If you consider safety in the form of it is safe for hearing, this is the only way we can preserve the hearing of patient. It is safe for facial nerve and contralateral hearing. These Meniere's disease patients have a tendency to develop Meniere's disease on opposite ear after 15-20 years. So if they are young patient in their 30s or 40s and they develop Meniere's disease, then there are high chances, more around 20% chance that they will develop Meniere's disease in opposite side in next 20 years. So this is the only surgery which can prevent the contralateral Meniere's disease. So this is the surgical picture. What we do is we go, I will show you the approach once because that approach is same throughout all the other indications. So we go inside and if you see, this is the cochleovestibular nerve. So the cochlear nerve is inferiorly and vestibular nerve is superiorly. They both come as a single nerve. We feel it is a single nerve, but actually there are two nerves which are going together along with, and there is a distinct plane between the cochlear and vestibular nerve, and the third nerve behind it is the facial nerve. So we have to selectively cut only the vestibular nerve, and if you cut this vestibular nerve, what happens is there is complete deafferentation of single vestibular system. So now any changes in vestibular system will not be transmitted to the vestibular nucleus and cerebellum. So the central compensation will take over and the patient will stop getting any episodes of vertigo due to any peripheral vertigo features on the affected side. So this is the end of the Meniere's disease in this patient. So I will just show you a video. This is a video of retrosigmoid approach, MIRA, what I say. I will just go fast how we do it. It is, there are certain, like the position is, there are certain landmarks for entering into. So if you see, this is the ear, just behind the ear there is mastoid tip, sigmoid sinus and transverse sinus. So we do the surface marking of sigmoid sinus, transverse sinus, and then we raise the skin and subcutaneous flap in a double breasting manner so that CSF does not get a space to come out. This is a very important landmark here is emissary vein. So this emissary vein is, when we follow that vein, it will lead us to the sigmoid sinus because it is going to drain into sigmoid sinus, and we make a small craniotomy in the sigmoid sinus. So here we are seeing this is the sigmoid sinus, the blue color discoloration. And we cut the dura and we enter into CP angle. It will be lined by arachnoid. So we have to dissect the arachnoid. And when we dissect, we can see all the cranial nerves. Here we have focused mainly on two nerves, 8th and 5th nerve. So here there is a very distinct plane. You can see in microscope, it is very clear. Superiorly, this is vestibular nerve, this is cochlear nerve. So we find the plane between vestibular nerve and cochlear nerve. And there will always be this blood vessel between the cochlear and vestibular nerve. So if you go along the blood vessel, you can clearly, distinctly separate the vestibular nerve from cochlear nerve. We are not doing anything to the cochlear nerve. So hearing of the patient will remain the same as it will be in the preoperative period. And what we do is we just cut the vestibular nerve completely. We have to see that we have cut it completely because the main function of this surgery is to deafferentiate the vestibular system. So once all the nerve fibers of the vestibular nerve are cut, both the end will get spontaneously retract away from each other, and there will be a gap between the two nerves, the two nerve cut endings. So that is the surgery. This is just showing the facial nerve behind. And after the surgery is over, any surgeries, all the surgeries we will discuss. We fill the CP angle again with saline, and we close the dura in multiple layers. And then we use bone pate from the patient to close the craniotomy defect, and this is the final sutures. So this is how all the other indications also, the steps are same. The only thing will vary is on which cranial nerve are we working. So next important indications are these vascular compression syndromes. These were not known till 1970s when Dr. Peter Janetta, a neurosurgeon from USA, described this, when he found that previously we were thinking that trigeminal neuralgia and certain cranial nerves anomalies are due to some peripheral problem in the trigeminal nerve, but it was found out that all these vascular compression syndromes happens because when the cranial nerve is exiting from the brainstem, there is a intermittent zone which is called as root entry or root exit zone, depending on whether it is a sensory nerve or a motor nerve. So that part of nerve is little sensitive because it is the axons are covered by oligodendrocytes, which are CNS cells, and the peripheral cranial nerves are covered by Schwann cells, which will form myelin, which will prevent demyelination of the nerve. So that small area of the nerve does not have a good layer of Schwann cells, and these are the areas when it comes into contact with the blood vessels which are normally located there, and these cranial nerves start getting demyelinated and the patient starts getting symptom. So there are, as we saw in the picture, there are different cranial nerves and there are different blood vessels, the arteries and veins, which are in close contact with this root entry and root exit zone. So there are various controversies why it is happening more in this cranial nerve and why it is not happening in other cranial nerves. But it is usually seen the nerve which has longest area of root entry or exit zone will have the highest incidence of that disease. Like trigeminal nerve has a very large root exit and root entry zone, and it has a very close, it is always in a close proximity with superior cerebellar artery. So this is why trigeminal nerve is most commonly affected by this vascular compression syndrome. The second most common affected nerve is facial nerve. So when the facial nerve is affected, patient will develop hemifacial spasm. I will show you what is hemifacial spasm video, and then we will know how it affects the patient's life. And if it affects the glossopharyngeal nerve, it will cause glossopharyngeal neuralgia. Some of the nerves are not having any vascular compression syndromes, like 12th nerve, despite being completely compressed by vertebral artery, it is not so. We don't know exactly why, but might be they have a myelin sheath beginning from its root exit zone. So how do we diagnose this patient? Any patient with vascular compression syndromes, they will have a neurovascular conflict or a secondary non-vascular cause. There is nothing like idiopathic trigeminal neuralgia or idiopathic hemifacial spasm. So they will always have a cause, and MRI plays a very important role in identifying the cause, whether it is a vascular cause or a non-vascular cause like a tumor or multiple sclerosis. So we have to rule out the tumoral and non-tumoral causes of all these syndromes. And if it is a neurovascular conflict, then we have to suggest surgery. All the disease like trigeminal neuralgia initially are managed with medicines, and more than 70 to 80% patients will do good with medicine over next 5 to 10 years. But as the period of trigeminal neuralgia increases, more and more patients will develop significant complaints despite taking adequate medicines. And those are the patients who we have to consider for surgery. So the surgery has 3 steps. First, we go with a 30-degree endoscope and do the mapping of the whole CP angle. Then we know the exact vascular loop which is causing the compression of the nerve. We, with the microscope, with 2 hands, we do the microvascular decompression. And then after we have done the decompression, we go back again with endoscope and confirm that the decompression has been done adequately or not. So I will show you some of the example. Like this is a case of trigeminal neuralgia. We can see there are two branches of superior cerebellar artery, the rostral and caudal. It is completely displacing the trigeminal nerve. And we can see when we decompress the nerve, we can see the demyelinated nerve also. There is change in color, there is change in thickness of the nerve. So what we do is we put Teflon pledges between the superior cerebellar artery and trigeminal nerve, and these Teflon pledges do not cause the compression of the nerve as it is caused by arteries or vein, and the patient is cured of trigeminal neuralgia. So this is another case where there are two arteries. Here the superior cerebellar artery and anterior inferior cerebellar artery, both are causing compression. You can see the change in color in trigeminal nerve here. That demyelination has been caused because of continuous pulsation of these arteries along the nerve. And we have to decompress both the nerves, both the arteries. So we have done that. I have missed the microscopic part because it will take too long to show different cases. So we have put Teflon pledges between both the arteries and the nerve. So this is nerve, this is superior cerebellar artery, and this is anteroinferior cerebellar artery. So again, here there are multiple. Now I am going progressively to more and more complex cases. So first it was only one artery, then there were two arteries. Here there is superior cerebellar artery, anteroinferior cerebellar artery, and a vein. So anything which is in perpendicular contact to the nerve is affected, is one of the cause of the neuralgia. So we have to treat all the causes. If you leave behind one of the vessels, the patient will not have good result. So this is again, there are three blood vessels. Here it is at the nucleus, trigeminal nucleus, but we have to take into consideration even the nucleus, because here the nerve is exiting from the nucleus. This is, so these three vessels, superior cerebellar artery, ICA, and vein. So vein, if there are other veins in the CP angle, we can cauterize the vein. So we have cauterized the vein and we have put Teflon between ICA, superior cerebellar artery, and the trigeminal nerve. So, and this was not in contact with the nerve, so we don't need to do anything. So this is last example where the complete vertebral artery was touching the tentorium and we could not see the trigeminal nerve at all. So when we went inside, we had to do work without seeing the trigeminal nerve, but this is the vertebral artery and it is a strong artery, so we can displace it with blunt instrument. And we can see there were two more vessels, the ICA and PICA, which were all the three were completely impinging into trigeminal nerve. So we have to separate all the vessels from the nerve by different pledgets of Teflon. And this was a unique case where there was no artery. And he was one of our colleague, doctor, who had been practicing taking 400 milligram of carbamazepine 4 times a day, and he could not sit in OPD. He was a physician, so he could not sit in a OPD, and 3 times MRI was done, and MRI was not showing any significant artery. So when a contrast venogram was done, we could see there is a very small vein which was perpendicular to the nerve here, and this vein was being missed on MRI. We were also missing it, but because the symptoms were so severe, and as we know, trigeminal neuralgia is considered as a suicidal disease. The pain is so bad that some of the patients starts thinking about suicide. And this was one of the case, being a medical colleague and with a suicidal thought, with severe trigeminal neuralgia not controlled by medicine. We told him that we'll take a chance because there is no artery, but at least 10 to 15% of patient has veins, and this patient has only one vein and nothing else. And that vein, when we cauterize that vein, now it is almost 10-11 years that this surgery was done, and patient is completely symptom free and is successfully running 2 hospitals. So there are some patients which will not have ideal MRI picture, but if the symptoms are very classical of trigeminal neuralgia and patient has significant pain which is not resolving with medicine, we have to consider surgery. This is one of our cases where patient was done surgery in 2016 or 17. The patient had very good pain relief for 5 years, 4.5 years, and then he started developing again pain. So we advised him surgery, and we went back. We saw our Teflon was very well, our artery was far away, but a new vein had developed here. So we can see this new vein has developed here. So it was not there previously because it developed. So we just cauterized this vein and we did not do anything to the previous Teflon, and patient was symptom free again. So trigeminal neuralgia has a vast way of presenting, and initially most of the patients are treated by medicine very well for 3 to 4 years, but there will come a time when the dose of medicine will keep on increasing and patient will have less and less benefit, and then we should consider surgery. Surgery is highly successful. We have done now around 102 cases with a mean follow-up of 4 years from 2013 till date. And I would like to say that we do all these surgeries together, myself and Dr. Rakesh Lohana. So we work as a team and we do all our lateral skull base surgeries together, ENT and a neurosurgeon combined. And we get very good result. At present, our success rate is up to 98%. And but trigeminal neuralgia is known to cause recurrence if you follow them for long duration. As I showed you one case, due to development of new veins or developing of Teflon granuloma or other things. So over next 5 to 10 years, there may be 5 to 7% of recurrence, but otherwise also it has a very good success rate of 94 to 95%. So next indication is hemifacial spasm. Just before discussing what is the treatment option, I will just show what is hemifacial spasm. So as you can see in these patients start developing unilateral spasm of muscles. So it is more common in females compared to males. But so you see that this patient has a socially very embarrassing position. If they are working, if they are going into society, they stop going into society because it is known as aankh marne wali bimari. They say ke, so as such they don't have any pain, they do not have any other dysfunction, but this patient starts developing unilateral spasm of muscles of one side of face which are supplied by facial nerve. So sometimes it is so bad that the eyes closes completely and they have a functional blindness. So these are the patients, male patients. So a few of them are actually doctor, anesthetists, and some of them were teachers who took voluntary retirement of services because of their students. It was very embarrassing for them to teach students with this disease, and especially girls. If he's a male teacher and if he keeps on blinking his eyes, so it is a quality of life issue. It is not a very serious life-threatening disease. But as a doctor, if you are continuously blinking in front of your patient, it is very embarrassing. So this is what is hemifacial spasm, and now we will come to the management of hemifacial spasm. Usually, this is spasm of facial muscles, and it is caused by compression of the facial nerve by, this is the facial nerve here, and this is the vessel, pica. So complete continuous compression of this nerve with this vessel causes demyelination. This is the facial nerve, this is the vessel, and it should always go in a perpendicular way. So we can see here the nerve was demyelinated here. We can see the change in color of the nerve. So this is the normal nerve, and this was the demyelinated nerve of the facial nerve. And if you separate again here the vessel from the nerve, the patient will be free of disease. So these are again different cases. Here the endoscope is very important in these surgeries, because in facial nerve, if we see that this is the loop, it can be seen by microscope, but this loop is easily missed on endoscope. So if you go with an angled endoscope, this is the medulla, this is pons, and this is the root exit zone of facial nerve. And exactly at the root exit zone, there was a blood vessel. I am sure this will be missed if you do only with microscope. It is very difficult to see this vessel. So we combined both endoscope and microscope, especially for this hemifacial spasm patients, and they improve the result by at least 10 to 15%. This is again another case. It was multiple vessels around the facial nerve, and very complicated case, which we were doing live in one of our conferences. So we could not see the facial nerve. This is the eighth nerve. Facial nerve is behind the eighth nerve, and we could not see. There was vertebral artery, there is pica, so multiple vessels. And so we can see this Teflon sponge. Now we have kept a sponge between different arteries, and this is the facial nerve here. So mainly the message is, in hemifacial spasm, there is no medical treatment. None of the medicine like carbamazepine or any anti-epileptic drug or any anti-central muscle relaxant helps the patient of hemifacial spasm. So the only two treatment options for these patients are Botox injections or surgery. Botox injections will work only for 3 to 4 months. And if we give repeatedly, there will be weakness of facial muscles, and some of the patients even develop antibodies to Botox, and they do not get results with Botox. So the only treatment options for these patients are surgery, because we have seen so many patients taking multiple medicines, but medicines does not help in hemifacial spasm for sure. So the success rate for this surgery is around 90%. The result compared to trigeminal neuralgia is less, because this surgery is much more challenging than trigeminal neuralgia. So result is less because of surgical inadequacy, and not that the cause is different, but this surgery is much more difficult. We have to work at angles, and there are important structures around facial nerve. So if you try to manipulate much, patient can have vertigo or hearing loss. Now, the last few slides about some of the tumors of CP angle which we can do with this approach. So this is a large epidermoid. Epidermoid is like a congenital epithelial pearl remaining in the cerebellopontine angle, which develops into a large tumor-like epidermoid. It usually happens at middle age, between 20 to 40 years of age, and this patient presented to us with hemifacial spasm again. So when we did a MRI, he actually did not have a vascular loop, but the tumor as a cause of compression of facial nerve. And this is the immediate post-operative result. So these patients, this is the microscopic picture what we get. So if we see with microscope, we will feel that we have removed everything. But when we go with an endoscope inside, we see that we have left a lot of tumor inside, and which we could not have seen working with a microscope alone. This is the facial nerve which was completely thinned out because of the tumor. And this tumor is, the good thing is, it is a suckable tumor, and it is a very avascular tumor. So it does not cause bleeding unless you cause injury to some blood vessel. So slowly and slowly you have to remove the entire tumor. And so this was before removal of entire tumor, and then we removed it again with the help of microscope and endoscope. And at the end, the patient was completely cleared of all the epidermoid tissue. Then we thoroughly washed this CP angle with 2 liters of saline, because there are some epithelial flakes which are lying here. So we have to clean everything. Otherwise, patient can have afebrile, means meningitis, non-septic meningitis. aseptic meningitis. And this is the last indication, a small acoustic neuroma, which is of less than 2 centimeter of size, and we can do with this small craniotomy approach. Otherwise, normally we do these surgeries by another approach called translabyrinthine approach. But very few tumors which are small and where we have chance of preserving hearing, at that time we can try this approach. So this approach may not be. So we have diagnosed that it is a facial, not a facial nerve schwannoma, it is an acoustic schwannoma. We progressively remove the tumor and we have to preserve the facial nerve and cochlear nerve. So this is the final picture after we have removed the entire tumor. And this will be this was the preoperative MRI and this is postoperative MRI, where there is complete tumor-free disease and the patient has normal facial nerve on day 2 of surgery. So final slide about complications. This is really a challenging field, and there are some complications which are very critical. So we have to be completely trained in this approach. The most common complication is CSF leak, because when you open dura and do this procedure and then you do watertight closure, you do multiple layers of closure, but then also usually in 4 to 5% of patient, the CSF tends to come out from the wound, but it is not a major complication. You have to act fast. You have to take the immediately sutures from the wound wherever it is coming. And if you act fast and do not depend on medical treatment or lumbar drainage, you can prevent any other complications like meningitis. So normally the world's largest series, they have CSF leak of around 2 to 3%, but most of them can be managed by local suturing. We had one patient who developed meningitis and we had to treat the meningitis for next 14 days. So it is important that whenever patient develops a CSF leak, we have to close it immediately. And then there were 4 cases of revision surgery or re-exploration, 2 of them due to infection in the wound. One, the trigeminal neuralgia recurrence that I showed you, and one was the hemifacial spasm patient, which she did not get result, but we knew exactly what was the fault and what we have missed. So we went back and did the surgery, and patient was solved of the hemifacial spasm. Sensory hearing loss is one of the complications of CP angle surgery, because cochlear nerve is a very, very sensitive nerve. And if you don't care about its blood supply or about it, if you cause physical injury to nerve is very rare. But most common injuries when there is a small labyrinthine artery developing from ICA. And if you cause injury to that labyrinthine artery, patient will develop sensory neural hearing loss. So our 2 patients of hemifacial spasm developed sensory neural loss, one with mild to moderate hearing loss and one patient had a severe hearing loss. And 3 patients of epidermoid developed hearing loss, because here in epidermoid the tumor is so vast and it impinges into all the arteries and veins. So when you try to remove the tumor, the arteries goes into spasm, and that is how the patient has hearing loss. Permanent cranial nerve palsies are rare apart from sensory neural hearing loss, but temporary facial weakness can happen in patients in different surgeries like hemifacial spasm or epidermoid. And we did not have any episode of subdural hematoma or vascular infarct and insult. We did have, out of this is the study of around 165 cases, and we had 2 mortality. One of them had a mortality due to massive MI post-operatively on day 2. So it was not an intraoperative mortality, but it was mortality within the operative period of patient. And the one patient of epidermoid developed large contralateral temporoparietal infarct. So this is a very rare pathology and exact cause is not known, but patient we operated in posterior cranial fossa, and patient developed a large infarct in anterior cranial fossa. And over the next 1 month, despite various resuscitation measures, we could not protect this patient, and he died. So this is the complications, and at the end, I would like to pay my gratitude to my teacher, Professor Jack Mannion, with whom I was trained, and the book we have written together. He is the master of this field and actually the original person who devised this technique. He was the first in 1991 to introduce endoscopes in CP angle, and now endoscope in CP angle is becoming more and more common. But in like 34 years back, it was not thought that we can do surgery with an endoscope in a CP angle also. So thank you. We'll be open for questions.
Thank you, Dr. Bhavin Parikh, for an excellent talk. Very good, videos also, and we could actually see so many structures we usually used to see during our first MBBS dissections in anatomy. So wonderful, views on this endoscopic surgery. And I really wonder what was happening to all these patients before this technology was, in use. I'm sure they must be suffering a lot. I mean, before a couple of decades or 3 decades back.
These surgeries were already done. Thus, what we have done is just to improve the success rate. And for Meniere's disease, actually, no one was doing surgery before with this success rate. But trigeminal neuralgia surgery is quite popular in India by different approach. Our purpose is to increase the success rate.
Right.
And for Meniere's disease, yes, it was not available. This option was not available to the patient.
I see Dr. Rakesh Lohana, your colleague, who has been.
Yes,
been
I was
surgery.
also. We have done all these
Rakesh,
cases
if you can
together.
make some comments now, we'll be happy to listen to you also.
Yes, sir. Thank you. Thank you so much. So yes, we are really getting better at it, and the basic purpose of presenting this talk to this august audience is basically to increase awareness. There is still good number of patients with especially hemifacial spasm who are suffering a lot, but because of fear of poor outcome of surgery, probably they are not reaching to the proper care center. So the surgery has become really safe now, trigeminal and hemifacial, with endoscope and better microscope and better experience, and can get good results in most number of patients. Yeah, thank you.
Thank you so much for those comments, and really, I appreciate, because now with Saturday Club of Baroda being archived on YouTube, this video can be seen by many patients also. It's an open
Yes.
access channel. So
Thank you,
thank
sir.
you very much for your comments, and we look forward to more such guest talks from you also.
Yeah,
So,
thank you. Yeah, we'll share some. Yeah.
yeah, from the audience, any questions, comments? Jagdish bhai.
No, it's a very wonderful presentation, and congratulations, Bhavin, for this excellent work. In fact, doing endoscopy and microscopy together is more challenging. So your pictures, videos have been excellent and wonderful work.
Hemant, you want to say something? Dr. Hemant.
I am saluting the human skill, the sadhana of these two surgeons, where everything fails and the risk is so much. And the ultimate thing is, Bhavin Bhai said at the end, what are the complications and why it happened. So this is a journey of surgery, which I think they will take forward for benefit of lot of patients. So I salute them and I wish them well.
Yeah, thank you so much, sir.
So, Dr. Lohana and Dr. Bhavin, this 165 is a large series. I mean, and have you had any publication on this or not?
So, till now, not our cases, we have not published, but now we have to publish, because I had published quite a paper with my teacher in France about his patients, but our patients, still we have not published anything.
It's a good number of series, right? 165
Yeah.
is
Yeah.
Now it is
Especially,
now
sir,
11
hemifacial
years we are doing it. And we both were actually trained by Professor Manyan himself, coming to Baroda at Venus Hospital almost 3 times, and he taught us because we were not able to operate in France. So he used to come here and teach us personally, and that was now 11 years, and now we are both quite confident and we are doing quite a good amount of work.
Dr. Rakesh wanted to say something. Yes.
Especially, sir, trigeminal neuralgia, even with microscope, majority of cases would get good results. But hemifacial spasm, especially, we are doing good numbers now. That series is pretty big in India, I would say.
Mhm.
Any publication we have not done, but any Bhavin is presenting on his platform, and in this month, and we have a conference, national conference of endoscopic neurosurgery in Mumbai, and I am presenting the similar talk, endoscope assisted hemifacial spasm there. So we are active on a conference of that, but publication is not there. But yes, it's pretty good series, and we are happy about it reaching there. And it's patient to patient. Like one patient gets happier, they have a maybe group of Botox guys, and one of the patients send another patient. So that's how we are going there.
Wonderful, wonderful. So, are there any more questions or comment from the audience? No. So we end the session here. Thank you, Dr. Bhavin, Dr. Lohana, for
Yeah,
this
thank you so much. Yeah.
presentation, and we look forward to such more talks in future. Thank you so much.